Hello, 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 hello. We will wait a little while, let everybody start coming in as we begin to prepare for Dr. Blazer and Christina to come on. Thank you, everybody, for tuning in. We have about 5 minutes before Dr. Blazer will be logging in, and we will bring her up to the stage so we can all see her. I hope everybody's having a great day. It's pretty warm here in Virginia, so I hope it's as warm there where you are. I see Running for Medicine is here already. I'm just waiting on Dr. Blazer, and then we'll start getting everybody on. So today is the doctors, and we've had Dr. Blazer with us before, and she's given us such great information. She was with us last year for our summit, and she's done so many different special speaking engagements for us, and she gives such great information and just gives us a wealth of good information. So you're going to really enjoy her. Oh, welcome, Jim and April. First time to join. Thank you for joining. I appreciate you. Hi, Jennifer. Hi, Briella. Hi, Shashi Todd. I'll try it. Our place doing. Shakirin. Running to Medicine. I'm going to get you in a minute. Just waiting on Dr. Blazer. But I hope everybody is having a great day. So I wanted to come on just a little bit earlier and hope that you guys are having actually a good Lupus Awareness Month, because it has been a whirlwind of a month. A whirlwind of the month. Welcome, Sashi Tad. If I'm getting your name wrong, I apologize. I'm trying to read it from this little itty bitty screen, because you can't really go live from your actual computer on Instagram. Maybe you can, but I just don't know how to do it. But I appreciate everybody whose first time is here. Tell me how your Lupus Awareness Month is going. Have you been sharing awareness with your people and, educating people about lupus? Let me know what's going on with you all. All right, let's see. And y'all just bear with me, because I'm trying to do 2 different things at one time while I do this. It is 6:58, so we have about 2 more minutes before we begin. Go ahead and tell a friend. Send this live to a friend that you think would be able to use this valuable information. I'm going to be talking about medical gaslighting and the different things that the disparities that some lupus warriors may have to go through, or people just in general with chronic illness have to go through. I know I've experienced it, I'm sure, on your journey with your chronic illness or with lupus or whatever the case may be. That you've heard it before. You might not have realized what it was, but you've definitely heard it before. I'm just going to put a quick welcome in the chat. And I see Dr. Ashira Blazer is on, so we're going to bring everyone up. And we're going to get Dr. Blazer on first, if I can figure out how to do this. I see you, Dr. Blazer. Let me figure out how to get you on here. There we go. I'm usually doing StreamYard, so let's see. I guess I do add as moderator, right? Let's do that. And oh, here we go. I know how to do it now. I don't know. Do you need to be on your phone? Maybe. You might need to be on your phone. Let me try and get Christina on first. Then let me see if it'll work with her. Let's see. We're working it out. We're working it out. We've only been doing this for what, 2.5 years? Okay, let's see if I can find. Running to medicine, would you send me a request to be on? And then we'll figure it out. Let's see how we do this. Let's go here. Here we go. Invite. Okay, I did. Oh, I'm getting it. I'm getting it. I'm a little slow, y'all. We getting there. Hi.
Hello, how are you?
I'm good. Let's see if we can get Dr. Blazer on as well. I'm so happy you're here.
Oh, thank you all for having me. Thank you for this opportunity.
Oh, I love it. I love it. I'm so excited to hear from you. Let's see. They should make it just a little bit easier to get people
I know.
on. It's like you have to go searching.
I actually called Dr. Blazer and I said, "Hey, how do you work this? I have no idea."
I'm glad I'm not the only one. I'm on this thing every day, and it's
Yeah.
still
No, you are
kind of
not the only
difficult.
one.
Yeah, I'm inviting you, Dr. Blazer. Let's see if it will send in. I don't know why it's not sending it. Let's come out of that and try it again. How are you today?
I'm doing
Okay,
well. It's very warm
good.
in South Texas, so
Oh, okay, yeah. I know it's warm there.
oh
I
yes.
know it's warm there. All right, let's try and take her out as moderator. Maybe that'll do it. Wow, this is so fun. Trying to figure that out.
I would help you if I knew what I was doing, but
I
I do
know,
not.
right? No, I know. Let me try and get this. Oh, here it is. Let's try it from here. You gotta love technology, though.
Yeah, no. I mean, it's advancing, but as much as it advances, you have to stay up to date and it's becoming more difficult.
It really is. Yes. Let's try it again, Dr. Blazer. Here we go. Let's see if this one will work. We're getting there, Dr. Blazer. We're getting somewhere. I see something trying to come up. Okay, moderator. Can I remove this moderator? So what's the weather there? I mean, I'm imagining it's super hot there because if it's hot here in Virginia, I know.
So the average temperature is about 95 daily. We have about 2 weeks of winter in January, so it's pretty hot.
Mhm.
Today is actually cooler than most days. It's around 88.
There we go.
Hi,
Hi.
Dr. Blazer, how are you?
Good. How are you? Yeah, it's strange. Apparently, if you are a moderator, you are
I
not.
see.
You cannot join. Yes.
I see. Well, we figured it
Now
out. Thank goodness.
Figured it out. Yes.
We were talking about the weather. How's the weather there in New York?
Actually, gorgeous. It was
Oh, I love
terrible
it.
for a while. Actually, like on Mother's Day, it was 46 degrees and raining.
Oh, wow.
Oh,
Yeah, yeah. And
yeah.
now it's quite nice. So
Awesome. Awesome. Well, since it took me so long to try and get everybody on, I'm going to get on rolling so I don't keep you guys too long. So, Dr. Blazer, just introduce yourself and then I have Christina introduce herself as well.
for sure. Yes. So I am Dr. Ashira Blazer. I'm a rheumatologist at Hospital for Special Surgery in Cornell, mostly doing research and academic work in lupus as it affects people of African ancestry. And I have recently started mentoring.
Nice.
Yes.
I love it.
Yeah, Christine.
And I'm a mentee. I'm Christine Loftis. I'm a second-year resident in internal medicine and hopefully a future rheumatologist. And so I look forward to speaking about lupus, learning more myself, and then also helping people of color affected by lupus and other autoimmune conditions.
Awesome. It's amazing because, usually when you see rheumatologists, it's always like a male, a white male.
Yep.
I
And
know, I
it's so
know.
different to see someone that looks like me thinks like me and has,
Exactly.
experiences like me. So absolutely, that is amazing. I love it. I love that you ladies decided to actually help me out and get some information out about medical gaslighting and just the disparities within care. So would you, Dr. Blazer, tell us what medical gaslighting actually is?
Yeah, so essentially what gaslighting in general is a phenomenon where you've got your lived experience, you understand what's going on, and someone else, usually someone who has a relative position of power to you, says to you, oh, that's not what's going on. And so it ends up being a case where either you have to trust yourself less or trust that person less. And a lot of times the power differential means that you start to trust yourself less because that person has some kind of authority. That person is supposed to be looking out for you. And it creates a scenario where you feel like you're questioning your own body and your own symptoms.
Right, right. Actually, that is it's pretty rough to handle too when you get that because you can get it from so many different ways, whether it's medically or someone in your family and even yourself. You can even gaslight
Yep.
yourself, right?
Yes, you can. Yes, you can. Yes, you can.
So, Christine, now that you're working with Dr. Blazer, and what do you think are like some of the signs that you're being medically gaslighted?
So I feel like we typically intuitively know our bodies. And so I feel like if you know yourself and you feel like something is wrong and you go seek like opinion from a specialist and they let you know that no, nothing's wrong, you're making it up in your head, that's not what you have. I think that, you have to be persistent because a lot of the times you will see patients who come to you after being seen by multiple physicians prior to being seen by you, and they've been told that there's nothing going on, that this would pass, and eventually you come up with a diagnosis. And so this
Right.
patient has been going through months and years of agony without being appropriately treated. And like Dr. Blazer mentioned, they feel like they trust themselves less. Maybe something is wrong, like maybe I'm just making it up in my mind. And so that's
Right.
typically some of the experiences that I've had in the past with patients.
Yeah. And are there like specific phrases that people need to look for, Dr. Blazer? Is it something that is very common? And who is it usually common with?
Yeah, so I would say it's one of these things where you know it's happening when it's happening to you, right? It causes a sense of confusion. It
Right.
causes you to feel like, maybe something doesn't jive with the way that I'm feeling, right? Um, I think that it happens systemically and also interpersonally.
Mm,
So we know that Black and brown women who have lupus are less likely to be diagnosed early, are less likely to be referred to a specialist, right? And in
right.
some of those interactions, it's that you're coming to a scenario where there's someone who's not culturally congruent with you, where there's someone who maybe can't relate to you or your background and may have their own biases, has to decide whether or not this fairly vague set of symptoms amounts to a diagnosis,
Right.
right? And so I think some of those differences interpersonally can lead to this gaslighting. And the other thing that leads to the gaslighting is that a lot of Black and brown people are seen in very stressed healthcare systems,
Mm,
right? So we know that there are disparities in being insured and well insured. Black and brown people are more likely to be underinsured. And so
right.
that means that a lot of times you're in a safety net hospital, you're in an overstressed clinic, right? And so the doctor may not have the luxury of time to really hear you out.
Mm, wow. And that's pretty interesting as well because being as those systems are so strained
Right.
and they may want to help you more, but they can't due to the constraints.
Mm-hmm. Mm-hmm.
Wow.
Yeah. Yeah.
That is just crazy. And as far as disparities, what's the history behind that? I know, Dr. Blaze, you spoke to us before about the disparities. I think it was last year we were talking about disparities in healthcare and things of that nature. How do you see it in your practice? And Christine, how are you seeing it as you're going through? coming up in the reins?
Okay.
Yeah, go ahead, Christine.
Oh, okay. So
Yeah.
I actually work in, I'm in residency on the South Texas border. So I see a lot of patients. It's a very unique healthcare system here. You see a lot of patients who are undocumented, uninsured. And you notice that a lot of these patients, one, they don't have the means or the access to to quality health care. And secondly, they're afraid to seek care in the United States because they are undocumented. And so I see a lot of the times some patients who are newly diagnosed with autoimmune conditions coming into the hospital setting because they don't have the insurance to go seek a primary care physician. And at
Mm,
this time, typically their disease severity is more advanced than it would have been if it was caught sooner. And a lot of
mm,
the times, you see that a lot of these patients don't have the medical knowledge. They haven't been
right.
informed of, well, this symptom is related to this disease condition, and so they have no idea what's going on. They're just afraid, and so they could have some women, they present after childbirth and they're having joint pain and they're having fatigue, and they're told that, oh, you're just tired because you just had a
Mm,
baby, or you're having joint pain because you're on your feet taking care of your infants, and they're dismissed. And so I see that happen a lot of times. As well as in our community, we have a very diverse population. Most patients are bilingual, but not all of the healthcare providers are bilingual in this area. And so that lack of being able to communicate to a patient, having a translator come in and get the translation is not always direct. And so you're not able to get all of the symptoms that the patient's having. And so there's a disconnect between what the patient is actually presenting with and then what your differentials are based on that. And so I think that becomes an issue as well.
Mm-hmm. Mm-hmm.
yeah, it becomes such a barrier to even give care at that point.
Mm-hmm.
Mm-hmm. And
Yeah.
I think, how I see it as an attending is I've navigated a lot of these healthcare systems, right? So I've worked in VA hospitals, I've worked in public safety net hospitals, and I've worked in private clinics. I'm sorry, private practices. Here in New York, it's private practice, and a clinic is a non-private. I had to learn that. Yeah, that's
Don't
not a
confuse
Texas
the
thing.
two.
Yeah, did not have that when I was in Texas.
Yeah, no, it's not the same.
Yeah, but I will say that it also becomes a systems thing, right? Because I am seeing the majority of my Black and brown patients at these clinics, at these safety net settings, right? I'm seeing a much more affluent and a much wider population in the private practice, right? And so when did I work in those clinics? I worked there when I was a trainee, right? So there's a skew towards having trainees in a number of these clinic practices. And so that means that you have someone who, well-intentioned, learning, but may not be expert. It's a system where it's harder to get medications. It's a
Mm,
system where people have to see more patients faster because it's one of these resources that's very constrained. So, I see that there's a racial split between who I'm seeing privately and who I'm seeing in the clinic. And that also contributes.
wow.
Mm-hmm.
It, so, I mean, we're sitting here, we're talking about, gaslighting and doctors gaslighting you and things like that. But there are so many other areas that we need to really focus on, even as the patient, to remember the things that you all have to go through as you're dealing with all the patients.
Mm-hmm.
It's not always just cut and dry that they're saying something wrong to you and you have to, figure it
Right.
out. You know what I mean?
And it's not. And I think the thing to remember is that most people are well intentioned. Most doctors are well intentioned.
Right.
People are not good at understanding where they might have biases, what other
Mhm.
things might be affecting them, or how
Right.
easy it is for someone to follow what it is that you say, right?
Right.
And so I think that being able to educate the physician healthcare force to be able to understand, these are all the ways that your care may differ for people in certain settings and people of certain backgrounds, I think is a big step.
Right. But let's talk a little bit about like the differences in medications and how someone might be treated differently, you know, as in their treatment and care. How does that work with the lack of Black and brown people in the studies to get these medications out? You know, how does that play into the whole disparities and things of that nature?
Yeah, so in a couple of ways. On the side of discovery, Black and brown people are underrepresented in all of our clinical trials, including the ones for lupus and other autoimmune conditions. Because these conditions are more likely to occur in Black and brown populations, that means that we have less information about the plurality of patients who will be using these medications, right?
Right.
The other is on the side of prescribing. So physicians are less likely to even tell Black and brown patients about biologic drugs, which are the newer, more targeted drugs, usually based on an immunologic function, right? So like all of your monoclonal antibodies, things like that, those are all biologics. So yeah, so physicians are less likely to tell minority patients about biologics, let alone prescribe them biologics, right? So, and a lot of this is perceived ability to afford, perceived, you know, acceptability of the medication. Physicians may think that certain populations don't accept it. But whatever the case, that can mean differences in prescribing practices, care, and outcomes.
Wow. So the whole perceived biases and, you know, it goes so far back, doesn't it?
Oh yeah. Yeah, for sure. For sure. It's a, you know, most institutions in the US, most longstanding institutions in the US were born during the time period where we had slavery and Jim Crow, because that's the bulk of the history of the United States, right? And so, you know, a lot of these discriminatory ideas start to be infiltrated into the ways in which care is practiced. And sometimes we don't understand how that history still lives and what we're even taught in medical school.
Right, how it's kind of conditioned into it.
Right.
Yeah, yeah. So Dr. Loftis, what do you see as the biggest barrier in caring for people who are dealing with any type of gaslighting and things of that nature? What do you feel is the biggest barrier between doctor, we understand the biases and everything, between doctor and patient? How does the patient work with that? When they see that barrier, when they see that bias come on them?
You know, we actually, Dr. Blazer and I were discussing this because depending on where you are, and like, so for example, here we have 5 rheumatologists for the entire valley. That's over 1 million people. So, you know, honestly, my advice would be, if you do not agree with what the doctor is telling you and you still have some reservations and you feel like you're not being heard, you need to seek a second opinion. It is your right as a patient to seek a second opinion if you are not being treated appropriately. However, we were also discussing that in my area, it's, you know, it's the wait time to see a rheumatologist is up to 6 to 7 months at times. We just don't have the available specialists here. But I still don't feel like you should give up, because you need to be persistent. If you feel like something's wrong, you keep showing up. And eventually I feel like you will be seen and you will be heard. Now, I think one of the ways that we can combat that is just increasing diversity in medicine, and just having more doctors of color taking care of patients of color, just because with that, you know, you're able to, patients feel more comfortable. They're able to discuss with you what they're feeling. And it's very different than going to a doctor where you feel intimidated with. You won't disclose everything that you're feeling. You won't disclose your symptoms. It's a very different environment. You feel more comfortable around people who are like you. And I feel like that's really important to kind of decrease these disparities amongst people of color, people with lupus, other chronic conditions as well.
Absolutely, absolutely. Because, when sometimes when you go into a doctor's office, you're already feeling a little, step back because you're like, he's a doctor, she's a doctor, she
Mhm.
knows more than I do. So you're already kind of like, I'm not going to question him. But it's like you said, it's important to advocate for yourself and to really find out what he's talking about. I told my doctor, can you just explain that to me, like
One
in
more time.
stupid terms?
Right, right.
Yeah.
To me, like, I'm not the doctor.
But I mean, that's the perfect way to test the therapeutic alliance, right? If you don't
Yeah.
understand something, say, hey, I don't understand that. Can you explain that in a different way, right?
Yeah.
And that is, if your physician won't do that, then you don't have, right? Because the vast majority, 95+% of care that you will receive will be at
Yeah.
your own hands,
Mhm.
right?
Right.
And so if I can't empower you as your
Mm,
physician to take care of yourself by explaining appropriately, I'm not the right doctor for you.
Mhm.
right. That's a powerful statement
Mhm.
because even though we think that the mission of the doctor is to take care of us, kind of,
Mhm.
sort of, when you go in there with that mindset, he's going to take care of me, he's going to teach me what I need to do for treatment. It is to empower you to take care of yourself better.
Right. Right.
So very
Yeah.
interesting.
I mean, knowledge is power, right? So if you're not able to get your knowledge from your doctor, right? And so, I see a couple of people saying, oh, there aren't very many rheumatologists here in South Florida.
Yeah.
And that's true. There are not as many rheumatologists as we need. That said, the American College of Rheumatology, the Lupus Foundation of America have good lists of rheumatologists who are more engaged in the community. As well, you know, because we're doing so much more telemedicine and telehealth care,
Right.
it means that
Mm,
there may be opportunities to find rheumatologists a little farther away from you, and
wow.
one who maybe if that person manages your care with a local physician can add some benefit from farther.
Wow. That's a very good point.
Mhm.
Because I don't think that people think that they can go somewhere else now since the whole pandemic thing. They don't think that they can go somewhere else
Yeah.
and care from somewhere else.
Yeah, yeah. And I think a lot of it too is like having support, joining support groups if you need to, joining the lupus initiative. You know, we talk about how patients need to like show up and show up and show up. Well, showing up repeatedly makes you tired and you forget things, right?
Right.
So like the lupus initiative is really great at having self assessment tools so that you can like write down your symptoms, things like that, and bring that to your doctor.
Yeah. And, speaking of that, I'm just going to address this question. Can you state that again, Rheumatologists of America? What was that? I'll
Oh,
type it
okay.
in.
So the American College of Rheumatology. So there's a membership for the American College of Rheumatology. So the rheumatologists who are listed there tend to be a little bit more engaged in the rheumatology community. Also,
Right.
Lupus Foundation of
Mhm.
America is really great for resources, and the rheumatology initiative as well. So that's for the any of my patients who are abroad. Uh,
Right.
that's one started by my colleague in Ghana.
Right. Which is how I found you with all that great information that you. It was amazing. Just amazing, amazing. Um, so it's so hard to deal with not being believed.
Mm-hmm.
And how do you how do you suppose a patient can say to their doctor, I feel like you're not listening to me, and I might be just giving the answer just like that. I feel like you're not listening to me. I need you A, B, C, and D. When they're short on time, how do they go about doing that?
Exactly that way.
Yeah.
Yeah. I feel like you're not listening to me. Or, can we schedule a time to talk after this because there are some things I need clarified, right?
Right.
Or, these are my goals. I came here and this is the kind of thing that I am prioritizing. Are you with me on that, right?
Right. Don't be afraid to to speak out for yourself.
For sure. For sure. For sure. And again, if you feel like that physician is not receptive, then you have your answer about whether or not that's a good doctor for you.
And then if you don't have enough people in your area, then try the telehealth portion and go from there.
Right. Right.
I love how you all are giving examples of how to go about going around it all. You know, I think that's important.
Mm-hmm. Mm-hmm.
Very important. Very important. So I know some of the things that I've heard just trying to get my diagnosis and things like that. Oh, you just need to lose weight. Oh, you're okay. Don't worry about it. It'll be fine. If I talk about a biologic, like when I was getting on Benlysta, unfortunately, I had a doctor that was like, you need to try this particular medication.
Mm-hmm.
But other people didn't have that. What do they need to be looking for when this starts to happen? You know, what are some buzzwords that some people might be hearing?
Oh, you want to go, Dr. Blazer? I mean, because you're more familiar with prescribing the biologics and things like that.
Okay. I guess. Okay. Well, I mean, I was thinking like some of the buzzwords, things like that. How do you know when this is happening? Yeah. So again, I think it's one of these things that you know when you feel, right?
Mm-hmm.
If you have made certain complaints, or you're telling your physician that, you know, certain things are going on with you, and that person doesn't offer to work those symptoms up, that may be a sign, right? You're saying that something is going on and you're worried about it, and that person says, oh, never mind, you know, that's not, you know, that's not important. This, you know, and sometimes patients do get, like, I cannot tell you how many people have come to me worried about cracking their own knuckles, and like, is it dangerous to crack my knuckles? Like, no, it's okay. You know, there's definitely a time to reassure as a physician, and a lot of what we do is reassurance. But if there's something that you're seriously worried about and that person is not working it up for you, that's a time. If you're in pain and no one takes it seriously, right? If you're in pain and there are no solutions, you know, there's of course a push away from opiates right now, which is a healthy thing. That said, you know, a lot of patients come in and they have pain, and the physician is not even trying to think about it or go to the pain specialist or anything like that. You know, you should not have to walk through your day-to-day uncomfortable.
Right. You see, I'm sweating here, right? This is ridiculous.
Yeah, no.
It's a perfect summer, y'all. Don't worry about it.
Listen, you should have been here in New York. It's very cold.
My goodness gracious. So yeah, that's important. I think what I'm getting a lot from both of you is speak up. Don't allow yourself to be a victim of anybody talking to you like you're not in pain. Yes or no? Am I good with that? Or?
Yes. I mean, I guess the part about it that I dislike is that it makes it feel like it's all on the patient, right? Like, this is a very systemic problem. And yeah, and unfortunately, you know, when we say, oh, what can you do? We're trying to tell you how you can be empowered, but also taking all that responsibility for being the person who advocates for yourself and knows when something's going wrong and all of that, right? Another reason why it's important to get a doctor that you have a good therapeutic alliance with is, if you get tired of speaking up, that doctor can see you, you know, so you don't have to carry that burden on yourself all the time.
Right. And that's important what you stated, because it's not something that's happened overnight.
Right.
It's something that has been happening from the beginning of time, you know, with the conditioning and things like that. So don't be too hard on yourself when things don't work out the way that it should, and you've been advocating for yourself. You know, it's not always work out to your favor.
Right.
Very good point. Tell me, what is, and we'll get a little further out now. What is classed as like medical negligence? You know, because sometimes you go into an office, and I've had this happen to a friend of mine where, oh, you don't have lupus anymore because your numbers are great. Now you have APS or, MS or something like that. How is medical negligence put in place,
Mm-hmm. Mm-hmm.
And that might be a little rough one to actually give a good, answer
It
that.
is. It's a little hard. I mean, I guess you can, if you want to try, and then I can
I
add.
mean, Dr. Blazer, you go right ahead. Like for us as trainees, as residents,
Right.
typically how it works is that, when I see a patient, I also have an attending above me. So I'll see a patient and it's also, it's under my attending's license. So we work out that plan together. So negligence, I think you see that kind of more frequently in like and people who are attendings, and it's typically you see it when you are in, it's more of like an intent, you are intentionally doing neglecting the signs and symptoms of your patient, like you're just not worried about it, you're doing it intentionally. Now I think a lot of the times we think of negligence in the fact that sometimes when patients are misdiagnosed or they're not, the disease is not diagnosed, but I don't think that's intentionally, that's not negligent unless it's intentional. So if a patient is like, if they're intentionally doing it and it's also they're not providing the standard of care that they should be providing you, then that becomes the issue. Now if it's now sometimes I think like what Dr. Blazer mentioned previously, um there's a knowledge gap in rheumatology, in other disease processes as
Mhm.
well, but we're going to talk about in rheumatology specifically because you see that, in residency you get you get like a block of training, maybe a month-long training, and you go out and
Wow.
you work in private practice and you're in your primary care physician, and you have this patient of yours that comes in with these symptoms, and like they can be sometimes vague. Sometimes the diagnosis is missed that way, but I think negligent is like willingly and knowingly not doing what's right for the patient going against the standard of care.
Yeah, and
But I don't think
I
that's a
think.
legal definition. I know Dr. Blazer can more elaborate
Oh
further on
yeah,
this.
no. I mean, I'll just say that usually when someone there's a standard of care, so there's a standard that you should be meeting, and there are goals that you're trying to get the patient to. If you are behaving in a way that causes harm to the patient, um, and is clearly a departure from the standard of care, it could possibly be negligence.
Gotcha. Gotcha. And I asked that because someone actually asked me to ask that question,
Oh yeah.
because they really feel like, sometimes it's not the right care. And it
Right.
could just be not the right care.
And that does happen. I mean,
Yeah.
I more often than not, it's not the right care, especially in something that's very nuanced like
Right.
lupus, and we're getting more tools for it, but it's not so cut and dry. Yeah.
So it's kind of scary to know that you only get that little block of time to learn about rheumatology, and then go out in the world and here you go on the job training type thing, huh?
Yeah, it's like that a lot, and um, you see people take up what they like, and so you see people who love cardiology, so they take more time in cardiology. I've personally taken
Absolutely.
more blocks in rheumatology because I'm interested in rheumatology, but I also try to take other rotations as well because if I plan on being a good rheumatologist, I need to know about nephrology, I need to know about GI, I need to know about the eyes, I need to know about the skin. So I want to take all of these rotations to become a well-versed physician, not just specializing in what I want to specialize, but also my background is in internal medicine. So you kind of want to know everything, but there are going to be limitations, of course. And so when you do have like conditions that are more rare, like, in rheumatology, and you don't see them that often, then the diagnosis is not that easy for, people who are
Right.
internists or general practitioners.
Yeah. Yeah. It's rough because when you think about it, a rheumatologist has to have a lot of information because lupus affects so many different things.
Mm-hmm.
Yeah.
You know what I'm saying? And I talk about lupus because that's what I have, but with any chronic illness, if it's,
Exactly.
affecting your organs and affecting different parts of your body, you have to know how that operates together. And I think it's good that you all are telling that part of it, because I think that we forget as patients that you're not the end all that meets all. You're still learning as well,
No,
So
exactly.
not to say that in a negative way at all, because it's not. We all have things that we still have to learn about our own disease, and you as the rheumatologist, absolutely. I
Mhm.
was trying to look to see if there were any questions. Lacey has a question. She said, I got a question. Why do doctors only go by what you tell them in order to diagnose you?
I'm by what you tell them. You mean,
I guess if I go into a doctor's office, what she's talking about is if I go into the doctor's office and I say A, B, C, D, then that's how they diagnose you from what you tell them. I guess that's what she's saying.
okay. I mean, so the most useful thing that you can do is do a great history and do a good physical exam. Most of your diagnosis, especially for things like lupus and rheumatology in general, is going to be based on the physical and the history. Um, Patients, again, know their bodies, and so they know what's going on and what's bothering them. And so getting that history is important. You know, um, Laboratory testing and imaging can also be helpful in making a diagnosis. But yeah, I do lean on the history and physical because the patient can tell me and show me what's going on with them.
Right. Absolutely. I know for me, it's a thing of keeping those records and keeping a journal of how you feel, because that's the only thing the doctor can really go on.
Yep.
He doesn't live with you, or she doesn't live with you. So it's kind of hard. I was actually diagnosed formally after the lupus attacked my intestines, but with history, knowing that my father passed of scleroderma, it started to all tie into each other. So
Right.
it's important that they are listening to what you're saying as to, what's going on with you, because it helps to make a correct diagnosis.
For sure.
Absolutely.
For sure.
JJP says, can you discuss issues related to misdiagnosis, overdiagnosis, and how remission is defined? Good question.
That is a great question.
Yeah.
So, as far as misdiagnosis is extremely common in lupus. The symptoms have, any one of these symptoms could go along with a different syndrome, let alone multiple of them together, right? Um, and in addition, a lot of lupus patients also have other autoimmune conditions. So they might have autoimmune thyroid disease and also lupus, or rheumatoid arthritis and also lupus, or Sjogren's and also lupus, right? And so it makes the diagnosis quite difficult. And then you add on top of that some of the healthcare issues that Black and Brown people face, some of those disparities that Black and Brown people face, and that these are the populations that get lupus, especially earlier and more severe, right? And you end up in a scenario where you can really get a lot of misdiagnosis.
Yeah, absolutely.
Mm-hmm.
It's it's kind of scary, but that's the nature of the beast of chronic illness
Right.
in general. You know, we
Right.
want to put it all on a doctor, but in all reality, you know, we can all get confused with what's going on with our bodies.
Absolutely. And I think that's another reason why it's really important to make sure that you're seeing your physician frequently, because sometimes these things develop and then, you have one symptom and then months later you have another, and putting that story together with your doctor can help you get to a diagnosis.
Yeah, that whole unpredictability of the disease, this, creates such a difficult diagnosis as well.
Right.
And she said, well, how do you define remission? I usually don't say remission because I feel like people usually associate that with cancer. I say like a quiescence or a
Yeah.
quieting.
Yeah. Yeah. So I don't speak in terms of remission for a couple of reasons. One, for the one that you just said, and two, because, you know, lupus is something that can get quiet and come back and get quiet and come back. And sometimes when people think of themselves as in remission, they say, oh, I no longer need to go see my rheumatologist. And I think that that can be a big problem as well.
Yeah, or I don't take this medication.
Yes.
Or I don't want to take this medication. Exactly. Oh, I'm in remission. I don't have lupus anymore.
Right.
I'm going to stop taking my medicines. As far as the closest definition to remission, I use low lupus disease activity. And so it's a state in which your lupus activity score that we measure in the physician office is low, less than 4. You're taking less than 7.5 milligrams of steroids a day. So we like you to be on none, but at least less than 7.5. And also when I do a sliding scale score as a physician, I think that you're doing well, less than 1. And so the reason why I use that as a definition is not necessarily because the person won't flare up again, but it's because I know that if that person reaches that state, then they're going to be less likely to have injury to their bodies due to lupus, or what I have to give them to treat their lupus.
Wow. That's good information. That's great information. I'm going to go down some. I found this interesting. It's just a comment, actually. She said, I've had lupus 33 years, longer than some doctors have been practicing. She probably knows more than some of the doctors.
She's not wrong. That's longer than I've been practicing.
Tracy, that's rough, man.
I'm 31, so.
You know, and I guess that kind of plays on you also, because you're going to a doctor, you're like, look, buddy, I've had lupus longer than you've been practicing.
And you've been born.
Yeah. But this is why it should be a partnership, right? This is why it should be a partnership.
Definitely.
Right. It's not the end all that meets all. Let's see. Tara says, now we're probably getting off a little subject a little bit, but that's all right. Is my menstrual cycle related to my lupus flares? Why don't doctors take my, I can't read this, adenomyosis seriously? Am I saying it right?
Yeah, adenomyosis. Yeah. Okay. So this is interesting because it's not related and it is. First, we have very little idea of how the immune system affects menstruation or the endometrial lining, right? There's more and more evidence that things like endometriosis and adenomyosis. So adenomyosis is like endometriosis, except that the endometrial implant ends up in the uterine wall. So essentially, when somebody has endometriosis, it's the lining of the uterus that usually gets shed during menstruation that goes outside into the body. So either it can escape and get into the pelvic wall or the floor, or or be near the ovaries and cause cysts, things like that, right? It can be very painful. It can cause heavy bleeding. It can affect your fertility, as adenomyosis is able to affect your fertility. But it also is likely related to an immune process. So there's some clues that people who have lupus are more likely to have endometriosis or adenomyosis. In some families where there's lupus, there's a higher risk of endometriosis. A lot of this is ongoing research, and we're learning more. But I think we have to understand, especially when we have immune diseases that affect women more, how these things interact.
Right. Why do you think that it affects women more? Do you think it's because of the hormones, or it's just so odd to me?
Yeah.
There's
a ton of research into this, and at the end of the day, we don't really know, but there are certain immune genes that are associated with lupus that are encoded on the X chromosome, and so people who have 2 X's can sometimes get 2 doses of it if one of their X chromosome is not turned off well enough. Hormonal effects for sure, maybe differential exposures.
right.
There are certain creams, like people who use like bleaching creams, certain creams have like mercury in them, and that's exposure that increases the risk of lupus. Perming, like the kind of things we put on our hair, things like that, right? So there are probably a number of reasons why.
Yeah. I want to thank you, ladies. I mean, this was very helpful. I think it's definitely something that we need to start discussing more and realizing as, as we're out in the world dealing with doctors and dealing with our own chronic illnesses to understand the disparities so that we're not so frustrated, number one.
Yeah.
And number two, so that we can learn how to get around those disparities and get the care that is proper for us.
Mm-hmm.
And go ahead.
Oh, I was just gonna say, sometimes it's frustrating to know that these things happen, but also it's more frustrating to think that it's you, right?
Mm-hmm.
So one thing about understanding this is you don't have to carry that weight. Oh, if I tried harder. Oh, if I did this. Oh, well, I'm making it up. Those things, right? Because it's not you. It's that there's, a system in place that is discrediting what you're saying.
Right, right. Someone said I saw the government doctor and she said my lupus cannot cause my lupus to act up. What? What do you mean, Lacey? I'm sorry. I had to read that one. I'm not sure. I'm not sure what that means.
Okay. Yeah.
That's fine.
Actually, one last thing I want to say is a big way that the healthcare system gaslights is by saying you need to lose weight.
Yes.
There's
Yes.
so many things that get blamed on healthy body weight. And honestly, we don't know what a healthy body weight is. The concept of a BMI was based on the perfect 70-kilogram white man, right?
Right, right.
And it was meant for insurance purposes.
Wow.
So I mean, the concept that the BMI cutoffs that we have definitely increase your risk of XYZ is just
Right.
rot. And a lot of times it's easier to say, oh, you need to lose weight than, okay, I'm going to take this symptom seriously.
Right. Wow. And I mean, what a great point because, often people, that's the first thing they say.
Right.
It is.
You just need to lose weight. You just need to exercise more.
Right.
Well,
You're
if I
having
could
joint
lose
pain.
Right.
Exactly. You're having joint pain, can't get up, but you need to exercise
Right.
more. And being undertreated. Yeah.
Right. Make it make sense. You
Oh,
won't give me any medication to help, but you want me to
oh,
exercise.
you have this rash of joint pain. You need to lose weight.
Right. Right.
Yeah.
Yeah, it makes no sense. But that it's important to know these things like, the BMI, it's outdated, it's not for us, it's just so many things.
Yeah. It actually, so one of my really good friends, Janina Jeff, has a podcast called In Those Genes. And she has one that talks about, weight, is it genetic? But she gets into a lot of really important topics, including the idea that this anti-fatness is actually rooted in anti-Blackness and discrimination, as is the BMI. And that this obsession with being under certain cutoffs is less based in science and more based in some of these historical, this history.
Wow.
Yeah.
And what's the name of our podcast again?
It's In Those Genes. And
the chat.
The episode is Baby Got Black, and she gets into all of the history of like anti-Blackness and anti-fatness and how there's very little understanding of how weight actually does affect health. Certainly not in all of the ways that doctors say, oh, if you just lost weight.
Right. Wow. I mean, just that last part just sent me over the edge because we don't think about these things. We just think that, the doctor is not listening and we need to find a doctor that listens. And there's so much more that is surrounded around the disparities and any type of gaslighting that people might do with us as far as medical is concerned.
For sure.
Absolutely. Thank you, ladies. I so appreciate you all. I appreciate you taking some time with me. It's 7:49. I don't want to keep you all much longer. I thank you, Dr. Blazer, for always being so open to be with us and share all your knowledge with us. Dr. Loftis, it's so nice to meet you. I hope that we see you again.
Hopefully so. And
she's applying for rheumatology.
Yes.
So she's applying for rheumatology this year. So I am very excited. Love having empowering women of color in rheumatology, especially one from where I'm from in Texas. So
Yes.
pretty proud.
No, thank y'all so much. I learned a
I
lot
love.
myself, so this is really good.
Awesome. I've loved the support. I'm so excited to see your journey. And I hope that everything works out well and that you get on that rheumatology circuit and we can see you out there.
Thank you so much.
Thank you, ladies, so much for all of your information. I appreciate it. Thank you, everybody, for tuning in. This has been The Doctor is In with Dr. Ashira Blazer and Dr. Christine Loftis. Am I saying your last name correct?
It's Loftis, but that's fine. It's
Okay.
fine.
I'm sorry, y'all. I'm sorry. But I appreciate all of your hard work and all of the discussions that you have given us. And I appreciate you coming on.
Thank you.
Absolutely. Thanks for having us.
Not a problem. All right, guys. So you all have a great night, and we're going to sign off for today. That's been The Doctor is In with Dr. Ashira Blazer. Talk to you all later. Bye-bye.